Everything said on this podcast is entirely for entertainment purposes only. This is satirical and should not be considered clinical advice. In any situation, please use your own clinical judgment, using your own knowledge, expertise, and research. Consult with your local eye department if you are unsure, and always act in the best interest of the patient. Do not listen to the things that we say and take it seriously.
Hi guys, thanks for joining us for another episode of Glasses After All. Today's an important one. They're all important.
They're all important.
Everything is important.
Of course. It's often the case that you see random first tests, whether it's a 9-year-old coming in, a 6-year-old, 3-year-old, even like a 45-year-old. Sometimes you can be surprised that, oh, I've never had a test before. And it's just really important that we make sure people are coming for their routine checks.
Yeah.
And the 45-year-old for his first test will have large oblique sills.
Yeah, of course.
That is just an unspoken rule.
That's it, definitely.
They'll come in with 250 sills
And a handful of ready readers.
at 50 and 140.
Yeah. A lot of course, eyes are eyes, and a lot that can happen to your or my eyes, or one of your patient's eyes, can happen to eyes of an infant.
Yeah.
A lot of the conditions we see, one of the largest risk factors is age, is being an elderly. So you're not going to see
Macular degeneration, cataracts.
age-related macular degeneration.
Age-related macular degeneration. You might see bests.
Yeah, absolutely. Cataracts is an interesting one because the typical nuclear sclerotic, that type of cataract that 90% of them are, that is, yes, age-related. But even in infancy, you can get congenital cataracts.
Yeah.
Causes, there is a lot of it is a lot of infant issues is gene mutations, okay? That's just, for example, when it comes to the eyes, a lot of causes can just be, trauma. Oh, it's a traumatic cataract, it's a traumatic retinal detachment, it's traumatic this, that, the next thing. That's a lot of the case with infantile issues and gene mutations. It can happen alongside other conditions called syndromic, something like Down syndrome, something like that, and other syndromes. It can happen alongside that, or it can happen on its own.
Yeah.
When it comes to the causes in and of itself, alongside the gene mutations, a lot can happen within pregnancy, because this is something that you already have. The trauma again during pregnancy. Chronic conditions, diabetes, etc., and other things can trigger hypoglycemia.
Drug use.
Yeah, all of that.
Drug and alcohol,
Yeah.
Alcohol in particular. I'm sure drugs as well, but
alcohol's the most common, and smoking is also another common one, I guess.
And infections. Can and during pregnancy so all these things, abusing substances, the trauma, or not taking care of your chronic conditions, and also infections that can also cause it. When it comes to preventing it, you can't always prevent it.
No,
okay?
Especially if it's genetic.
Precisely.
Yeah.
But just the things that we did mention, those things, you can take some things, do your preconception checks, do your make sure you're on top of your vaccinations, make sure you're not taking care of your health in the other manners as well, take care of chronic conditions, take care of so on and so forth, because when it comes to congenital cataracts, like any cataract, there's one treatment.
Yeah.
If it gets mature enough, and it might not, to be honest with you, not every congenital cataract does get to the level where it needs to be taken.
Yeah, I've seen plenty of congenital cataracts in adults.
You just leave it. Because of managing
slightly reduced vision.
Exactly.
Manageable.
Exactly. So, but if it does get to a point where it is getting in the way, whether it's inducing amblyopia or whether it's just really bad, it is surgery. Surgery. Another one that mentioned was age-related is glaucoma.
Yeah.
But you can also get that in. There's two main types. There is the juvenile open-angle glaucoma.
Yeah.
That I don't need to go into detail much because
self-explanatory.
It presents like normal glaucoma does. There's nothing really
in a kid
special. Exactly. It's just normal glaucoma in someone much smaller.
It's mini glaucoma.
The only thing that would be a little bit more tricky is because you don't routinely do IOPs on a child, so you basically only notice something that was off purely through your disc assessment. Yeah.
Yeah.
You wouldn't even pick it up on OCT because you don't.
Exactly, because you don't do OCT on
unless you
as well.
suspect.
Well, yeah, but in a routine sight test with an existing child, the only way that you can diagnose it or monitor it is through, like, notice anything is through
Through
that
ocular
discus. Yeah,
assessment, yeah.
exactly.
Yeah.
Which is even more difficult if you have only one, if it's first time sight test as well.
Yeah,
Yeah.
I mean, yeah, true. You can't map the changes
Yeah.
quite as well. I've worked in practices where they don't even take photos of children.
Really?
Yeah, they don't even take fundus photos of children. And
I mean, it's not clinically required, is it?
But it's
Nothing's
so-
required.
I
Except
mean,
for,
bulking
except
is
for-
required.
well, it's not if you do an ophthalmoscopy with the direct.
Okay, some form of ophthalmoscopy,
kind of-
regardless of whether it's direct
An
or
internal
indirect, is
assessment,
required.
an external assessment,
Yeah.
and any other
And a refractive
and
assessment.
a refraction and any other test that you deem appropriate is
Yeah.
what constitutes a sight test.
Exactly.
So yes, the fundus images are not required, but then they're
But
valuable in.
I
tracking
was just being a
pathology.
little bit devil's advocate, but yeah, you're right. It's not best practice.
So it is something that unfortunately could slip through the cracks a little bit
Yeah.
more. Thankfully, it's very, very, very uncommon.
Yeah.
And even then, it's the more common type of
The other glaucoma.
infantile glaucoma.
Yeah.
It's not infantile literally because that's got a name. It's juvenile.
Paediatric.
Yeah. So the primary congenital glaucoma,
Yeah.
congenital now, that's a lot less frequent than juvenile open-angle
Yeah.
glaucoma. But yeah, it still happens. This one's a lot easier to spot.
So with, if I'm getting my terminology correct, congenitals, they have it as on birth, basically.
You'd think
Is that not true?
the
Or they start
what
developing.
is causing the disease is set in motion at birth. The disease
Okay.
might not present as because glaucoma is the
You get the general thinning and things like that from birth.
Well, you get the because it affects the trabecular meshwork and the anterior chamber angle. That is there from birth. It might not affect the actual eye itself in terms of damaging the eye from birth.
Okay, so sorry, I'm gonna skip a step. So with the congenital, what kind of a glaucoma is it? So how does it present?
So elevated pressures.
Okay.
Anything under 21 is normally fine. I know
Yeah.
we don't really do IOPs for
Yeah.
children, but elevated pressure is one of the presenting symptoms with about 30 to 40. Okay.
Mm-hmm.
And I want to make sure I'm reading this right. So well, there's three symptoms. There's epiphoria, so watering of the eyes. There's photophobia as well, and blepharospasm, which is a result of buphthalamus, which is Greek for ox eye. Okay, that is due to the eye literally physically expanding, and that's causing the epiphoria, it's causing the watering, that's causing the blepharospasm, that's causing the all these other issues.
Is that so? It's would they look proptoed?
In a way,
But is the eye bigger?
the eye is physically larger.
Is it unilateral?
It's
Please say it.
I don't think it is.
It's like, oh, what big eyes you have.
Yeah, it's glaucoma.
Yeah. It's like, if it's unilateral, then at least you can like tell.
No, it's I don't think it's always is unilateral.
Okay.
Okay, but the thing is, it's not just the enlargement of the eyes. The enlargement of
Yeah.
the eyes produces this triad of symptoms.
Yeah.
Produces the blepharospasm, the epiphoria,
Yeah.
the photophobia, and those three things are what you're really looking out for.
Do we know the etiology of how it happens?
Congenital, mate. Genetic mutations. It's more likely if you have siblings with it.
Is it open angle as well?
No, it's
Close.
yeah.
Okay.
Because it's
Okay.
second
So
line
so
of
it's
trabecular.
the juvenile one is open angle,
Mm.
kind of like your posterior open angle
Yeah.
glaucoma, but
If you think
as a
of it
kid.
like primary open angle glaucoma.
And that's something that a child may
Did you
develop.
say posterior open angle glaucoma?
Primary, sorry. But that's something
What
that
do you think the piece
it's because when I was like
Big one.
I've got
Anyway.
anterior glaucoma.
primary open angle glaucoma, sorry. And that's something that can develop just in childhood.
It's not. Yeah.
You're not born with that condition per se
Not the same way as you are
with a congenital.
congenital.
So congenital, there is a deformity regarding your trabecular meshwork,
and the anterior chamber angle.
Yeah, and that leads essentially for you to have an angle closure glaucoma.
You could think of it that way.
Yeah,
absolutely. Harder to miss for obvious reasons.
Yeah.
Again, very similar.
So would the presentation generally be quite similar to angle closure, apart from the other ones that you mentioned? It'd be quite similar to angle closure glaucoma with the red eye and
absolutely.
Okay, and it's bilateral because it's a meshwork deformity.
There is
congenital.
So I mean, I'm not going to be able to cover literally every single condition that affects kids, but and even these ones are getting into the rare nitty gritty. Which.
So another one that you could have as a child. Well, you wouldn't pick this up yourself unless you miraculously.
You underestimate me.
Saw the uveitis before the child felt the aching pains in the bones. Is juvenile idiopathic arthritis.
Yeah.
When a child has got this kind of, juvenile arthritis that they have, it means they're more likely to have inflammation of the eye, which can lead to things like cataracts and glaucoma as a result of it. Which is why the patient that I saw recently was on a 6-month review at the hospital until about the age of about 14 or 15.
Wow.
Interesting.
So for all of the childhood, they had regular six monthly reviews at the hospital.
So that basically just put it out of your jurisdiction, and then you just like...
Yeah, as in I just wrote down that they were under the hospital review and it was all fine. They never had a uveitis flare-up, luckily.
That's good.
So it was quite good for that patient. But obviously...
What's the most...
Clearly, it must be more of a risk because NHS is paying them
exactly
every 6 months.
What's the most frequent you've had patient present or claim with uveitis? I've had patients say they get uveitis like 3 times a year.
Oh yeah.
Patients say they get it.
As in someone that has recurrent uveitis.
I've had a patient that just called the hospital. They just called it.
I just walk in. Hi Mary. Me again. Yeah. Just give me the doctor. Nice one. See you next month.
I'm not actually sure. I know someone. This isn't like frequent. Someone's like, I have it once every 7 years, and like on the dot 7 years.
Because the thing is, like,
they were like 70. They were like, I've had it for like 20 years. Like every single time it's 7 years on the dot.
I've had it 3 times. Like, you're not special.
Well, he's waiting for the third.
So you just had it once in a 7-year gap.
Twice.
We had it twice, 7 years apart from each other. Exactly 7 years.
I don't know if it was 20. It was like they were like oldish patient, and they've had it for a good number of years, and I only get it every 7 years or something.
I remembered it because for me, spotting uveitis is like a noteworthy test. Like it's abnormal. It's something that you need to go to the hospital. They're gonna give you medication. For her, it was just just had a couple months
another
ago.
thing. Yeah.
Again.
Not now. I'm on holiday.
Yeah, precisely.
Okay, so any other pathologies?
Loads. Honestly, so many.
Too many to talk about. We can't even begin.
That's us for today.
Don't ask me about these. There's too many. They make me upset.
Here all night and all day.
Get upset when I think about them.
There is congenital ptosis.
Okay.
Ptosis
self-explanatory, that one kind of.
Yeah. The kind of
blepharoplasty.
Well, yeah, but it happens when the levator muscle. It can happen for multiple reasons.
Yeah.
It's important not to just see ptosis and just think, oh, this is just.
Yeah.
Because it could be whatever. It could be Mark's gun. It could be Horner's. It could be Duane's. It could be third nerve palsy. It could be all of these things. And but congenital ptosis, separate from all of that, is when the levator muscle is maybe not absent, but infiltrated with fat and fibrous tissue, and that gets
not
in the
working
way.
well, basically.
Exactly, but it's not like a nerve defect.
But would it be something that's related to an underlying systemic condition?
That's what you have to discern. In and of itself, it's not.
Yeah.
But ptosis presenting in youth can be related otherwise. But that's not typically defined as congenital ptosis.
Okay, so congenital ptosis is just someone that's essentially born or with a ptosis, basically.
As a product of the levator muscle
not working as well or being absent. Yeah. So what is the treatment then?
Refer.
Well, yeah, but if it's surgery if it's a levator muscle issue, because then the muscle just isn't operating as it should, and we can't rely on that muscle to operate as it should. So just be.
And there's obviously the risk of occlusive amblyopia.
A few minutes ago.
Wait, no. So what is this? So, like, what do they do for this
Surgeries,
surgery?
Surgically excise muscle.
They reattach the joining point to somewhere probably higher up.
Okay.
Imagine they put sellotape on it, like in Tom and Jerry, but they're just doing that with
Okay,
the muscle.
so would that... I mean, I don't know if you'll know this, but would that mean that they'd basically have...
It wouldn't always be open.
Okay.
They could. The muscle still works. Is they've reattached the muscle side to somewhere else.
Okay. All right. Fair enough.
You know when you eat a chicken wing and the little bit of muscle that's
Yeah, no, I understand that part. It's just a matter of like the possible side effects.
Of course, the same way you can get people being overcorrected for a strabismus surgery.
They still have
like there's no surgery that is without risk.
I saw the best strab surgery. The patient previous note record said like 20 ectotropia, something stupid like that. Big tropia. She came in no movement whatsoever, with or without specs. And then she was telling me about it. She said the surgeon was amazing. She did like most of the surgery under the anaesthetic. Then she left like 2 or 3 of the stitches in. She woke me up and then she took me to a mirror, sat me down and said, "Where do you want it?"
No.
As in not exactly like that.
Yeah.
Oh my god.
She had her awake, looking in the mirror, and then she said, "I'm going to nudge it slightly further out because when the anaesthesia wears off, it's going to drop out a bit. So I'm going to overcorrect it like by 1 mil." And then it landed. It landed perfect.
That's
so nice. Very good.
It's the way that she said they woke me up and then they left a few stitches in and then they literally stood there like, "Tell me where you want." Just say when.
Goodness me.
That's really interesting.
Incredible.
So good.
Imagine having the confidence to just be able to do that.
That's really interesting.
Wow.
That's really cool.
One of the, in university at least, we're taught one of the many particular tests that you do for kids is red reflex.
Yeah.
And
I do that if like they are like either very, very infantile, like they brought a 2-year-old just to check.
And it's one of the few tests you can actually.
Yeah, exactly.
You need to
if they open the
exactly. It's like it's a 5-minute test anyway, so let me do something in it.
He's following my finger.
Yeah. Or if they're like very non-compliant patients, then I'm like, let me at least get a red reflex.
I mean, the thing with the red reflex, the one reason why it's so easy to do is because it just requires reflection of any light.
Yeah.
If you've got your recta, it's going to happen. If you have your volca, your ophthalmoscope out, you're going to hopefully get the red
paint
reflex.
torch. If you're hard enough.
You usually require a bit of a scope or something like that. Are you seeing a red reflex?
I just do it with your hand.
Mate, that's what's it called? Is it kappa? The thing.
What?
You know when you check the pupil reflexes.
Hirschberg and kappa.
Hirschberg and kappa. That's it.
Yeah, but you need a focal point light, a diffuse phone.
Yeah, you can do it with thingy.
Yeah, with a pen torch. Yeah, that's what you use it for.
So there are there's quite a lot you can pick up. Do you know what it says? Like on paper you can pick up things like retinal detachment, etc. That would have to be pretty bad. There'd have to be pretty bad retinal detachment for you to pick up on a red reflex.
The red reflex would just look a bit weird, and then like, ooh, what's this?
No, but you'd like the detachment would have to be quite large.
Yeah.
That's what I'm saying.
Or if it was fully detached.
That's what I'm saying. Like
at that stage, I mean, what?
No.
I mean, you want to get it flagged up, of course.
No. But the point is that in theory, there's a lot you can pick up from red reflex. On paper, there's a red glaucoma. If you're picking up glaucoma in red reflex, please send me an email. I want to have a chat.
How?
I would, but there's a few things that like you do red reflex to look for things like collarbone. Okay?
Yeah.
And that's because the posterior eye didn't close properly during pregnancy. You do red reflex to look for something like retinoblastoma. Okay.
Yeah. I had a patient where they were like 15 years old or something, and they came in, and the mum was like, we took a photo of him, and one of his eyes reflections was white, and I was like, ooh, that's not good. So he's 15, so I can get him onto the slit lamp. I do the red reflex first, and I'm like, yeah, crap, it's white. And then I look in, and it's just a massive amount of myelination.
Really?
Yeah. So I'm like, all right. And then I checked the previous, and it's myelination that has progressed, so it's gotten worse.
Okay.
Which is why they're noticing that there's a white reflex.
Yes.
So like, let me just refer it anyway, because it's something that's progressing.
Please tell me you got some follow up.
It was idiopathic.
Just growing and no,
No symptoms,
blind spot,
no.
nothing like that.
I didn't check for blind spots.
Did you do a visual field test?
I didn't know. I just referred it.
Retinal blastoma, which I'm sure you're glad it's not. That can present with other things, red eye, irritation.
Yeah.
These other issues and conditions that are a product of loss of vision, like amblyopia and so on and so forth. It is unfortunately one of the more common the red reflex positive results. It's 1 in 20,000 kids.
Really?
That sounds quite high to me. Well, I mean,
20,000.
Sure.
Yeah.
I mean, you're probably likely to see a few a year then.
No, 1 in 20,000.
Once a few in your lifetime.
Yeah.
We probably wouldn't because it'd more likely than likely be picked up by
the hospital.
The
nurse,
the ophthalmologist at the hospital. But thankfully it's a 90% success rate.
That's good.
And
I once saw what I thought was a retinoblastoma. And it was one of the first few days I was doing signal testing. So I'd always worked in my store. I was always in my store with my supervisor, who was my director. And then when I qualified, he was still there to knock on the door off. And then one of the first few days, I think he'd gone away somewhere.
Yeah.
I think he'd gone on holiday or something for a weekend. And the parents came in and said, saw this picture of her. They showed me a picture, which was like okay, this looks like it might be. Might be. I've looked at it myself. I thought, it might be, and then I thought to myself, but it's not at the same time. But it kind of is, but it kind of isn't. And I was in two minds about it. So
the thought process.
The thought process, and I swear, I said to him, give it a day, and I'll call you back tomorrow.
Okay.
Because they came out like 5. They came out.
If it gets worse.
Yeah, come back if it gets worse. No, I said, look, let me just check with my colleague who'll be back in tomorrow. And I woke up that morning having had a nightmare about retinoblastoma at 6 in the morning and started reading Kansky. And then I went into work and I thought, I'm just going to refer it. Actually, I'm not going to bother doing anything. I'm just going to send this.
Get any follow-up?
I got follow-up. It wasn't.
Okay.
It was it was an ISO, apparently.
An isometropia?
Yeah, they said it was the hospital saw her. She was 2.
Yeah.
She was 2, so it was can't get anything from her.
It was just
hospital said we did a cyclo-ret and it's +3 in one eye with a 1 cell and the other eye is next to nothing, so just prescribe them.
Did they know why you referred them?
I said yeah.
Make sure you wrote retinoblastoma.
Yeah, I did mention about the red reflex, and I told Dad had a picture
on a routine check. But no, that's
that scared me, honestly.
Janet, we've got another one of those random referrals.
Was it from him?
Give it to the optometrist.
Give it to the student.
Yes, an abnormal, retinoscopy result is also one of the things that flags up in red reflex.
Yeah.
Or a corneal problem like keratoconus.
Yeah.
Red reflex can pick up that.
No, of course.
Yeah.
It's another big one is ROP.
Yeah.
Retinopathy of prematurity.
But that
gets screened if they're born premature.
Yeah. Most of this does. Most of this is already screened, and especially this reason being is that the blood vessels in the eye, which is abnormal in retinopathy of prematurity.
ROP.
Yes. They have not grown properly, and they grow from week 16 to 36. And usually this issue is prior to week 32. If anyone's that premature, I think it's under 1.5 kilos or before 32 weeks, they're obviously good. They'll get screened regardless, but then they'll get extra attention. So it's unlikely that you will ever see this in practice, but
in case somebody brings in their home birth child at 3 weeks,
probably should just send them to the hospital.
To be honest, the retinopathy from premature that you probably would see is someone that's already diagnosed it.
Yeah.
So it's a matter of managing expectations at that point.
Yeah.
Oh yeah, of course.
There's 5 levels of this depending on how far it goes out, and it goes from anything from just a zone where there's no vessel growth, all the way into dramatic retinal detachment in the fifth one. As the stages progress, ridges form and the level of vascularity will go over the ridges. But again, you won't be needing to really diagnose any of that. There is treatment. The treatment is to prevent the vessels from growing in the avascular zones by laser.
Anti-VEGF?
Laser. Anti-VEGF is actually quite controversial. Okay.
I would assume,
yeah. But you'd think that would be.
If I hear blood vessel growth, I'd just say anti-VEGF.
But
PRP.
Laser, yeah, exactly.
Fair enough.
So it's
Interesting.
So yeah, but loads of other ones. Orbital cellulitis is another thing to be concerned about. Another obvious one, big, red, inflamed, so on. It's but as mentioned, there's we could sit here and just talk about every single disease that happens, and I've not even touched.
And this is just children.
we just
wait till they get older and they get AMD.
Just gets worse from day one.
We've barely touched the surface on this, but even if they're not coming in with you're not taking a photo or the patient hasn't got red reflex, you still need to enforce the importance of the fact that we still need to just keep checking it. Sure. Is there any reason why you would want to reinforce the fact that you do need to check kids even if they're not presenting with something like congenital glaucoma or something
or
like that?
Or being at risk of developing anything.
Yeah.
Yeah, I mean, ultimately you don't know what the state of the eye is until it's been screened. And the important thing, one of the things about the eye is that it's a window into the body in a way that isn't really accessible normally. This isn't specific to children, this is a general point. Obviously, for example, hypertensives, you can see the blood vessels of the eye directly, so you get a view of what the inside of the body looks like.
Yeah.
So that's not specific to children, of course, but there are a lot of things health-wise that you can probably flag up by looking at the eye. But then there's the obvious stuff, so colour vision defects, generally asymptomatic. The patient will think that's how the world looks to them, unless they've been doing a particular visual task and somebody's said to them, why can't you see that? Nobody's going to come in saying my colours aren't normal. They think that's their perception, they think that's what's normal. So you've got to be the one to pick that up, and you've got to be the one to advise them career-wise. I've got a fun icebreaker for the conversation of visual colour vision defects.
Yeah.
So I tell them that they can't be a pilot. I tell them that they can't. What's the other one?
Electrician.
I can't tell them you can't be an electrician, you can't be a pilot, and you also can't be a professional snooker player. But you can do amateur.
Fair enough.
And that usually eases the tension a bit.
Yeah.
Usually from mum. But yeah, it's just obviously a case of managing expectations with colour vision, telling them to tell the teacher to adapt resources to keep that in mind, and also just reforming that it's not anything majorly wrong. It's fairly common in boys. 1 in 13 will have it, and it's a genetic
8%, isn't it?
8%, yeah. Whereas much less common in females. But yeah, colour vision defects. But then there's obviously other things that you could miss if not brought in. For example, latent hyperopes. You could have +3 in both eyes, and they just sat there accommodating.
Trying to convince someone they need glasses when they really
when they can see.
When they come in +5 in both eyes, and they're doing this, and they're like just about reading 6/6, and you're thinking,
and they're like, I'm fine.
You can see it. That is true. However, you can see it easily.
No, but it's like when they're actually like a +3, but they can't really see anything over a 1. It's like, trust me.
Like as soon as you go anything,
relax.
As soon as you get onto +1, the spasming, the accommodation just goes out. Yeah. You know, I get this quite a lot. I just want to see what you would say. If a parent was to come to you and they're like, "At what age should my kid get their eye test done?"
That's a
what age would you put?
What I say to them is, are you having any problems, first of all? If you're having problems, come in whenever.
Yeah.
It doesn't matter if you're 3 or if you're 30. Come in if you're having problems or any concerns about the eye movements, especially in children, or if you're concerned about the vision, if you think you can't see what you should be able to see, given the age. When they're asymptomatic,
routine,
straight-eyed, and binocularly okay, what I say is bring them in as soon as you think that they're able to sit down and do an eye test. You've had an eye test with me today. you know what it entails. As soon as they can sit here and well behaved long enough to read the letters out and sit still so I can look in their eyes, bring them in for an eye test.
Yeah.
I just say 3.
3?
Yeah.
Who's ready at 3?
No, but like, okay. The first part, 100%, I think that's pretty universal advice. Any issue, any time, any person, any
Depends
place,
on the child, of course, by the way, but 3.
But no, like, I'm not waiting for them to sit down, because I've had, like, 6-year-olds that won't sit down. But to a certain extent, you just need to just test someone's eyes and just do whatever you can. So for me, it's like, but beyond that, typically around 3 years old.
I say 4, but yeah.
Okay, so I wouldn't even say we barely scratched the surface. We just barely even introduced the topic of scratching the surface. We will be going into more depth on a lot of this topic because it's just so much of our
probably be quite a lot of overlap as well.
Career. Yeah. No, of course. But thanks for joining us today, and hope to see you next time.
Thank you.